who's going to talk about the health pathways.
Good evening, everybody. As I'm sure you're all aware by now, Health Pathways is a joint initiative of the Northern Sydney Local Health District and Sydney North Health Network. It's an online platform that supports condition management, service navigation, referrals, and access to reference materials and educational resources. Next, Jude. As you can see, there are benefits for the patients, the clinicians, and the local health district. Since its inception in May 2017, they have developed 398 pathways that are live and 38 pathways in progress. And on average, there's almost 5,000 views every month. Under women's health pathways, there are currently 40 live pathways. The access details are on the bottom there, the website, but if you don't know how to get in, please contact Sydney North Health Network or myself and we'll give you that information. There's a few more pathways here that are not on the women's health section, but they are relevant for pregnancy. So go in and have a good look around. And then on the next slide, you'll see that we have 13 pathways that are currently in draft that will be added to women's health pathways. So we want you to get out there, log in, put the icon on your desktop. If you have PenCat top bar, the icon is already on top bar and that will take you straight to health pathways with no login required. And as you can see at the bottom of the screen there is a feedback button. If you see something that you feel is inaccurate or needs comment, please use that and that will take you straight to the Health Pathways team. Thank you, everybody. Now, I'd just like to introduce our two speakers for this evening. We have Talat Uppal, who I'm sure you're all familiar with. She's an integral part of our shared antenatal care program. Consultant obstetrician and gynecologist, VMO at Northern Beaches and Hornsby Ku-ring-gai, and a clinical senior lecturer at Sydney University. And she's just recently opened her own clinic in the Northern Beaches called the Women's Health Road. Talat's going to speak to the protocol and fundal height measurement. And our second speaker, who is going to speak to the genetic screening, is Dr. Mizia. Karen is an obstetrician gynecologist and a recognised subspecialist in obstetric and gynaecological ultrasound. She has worked in this field for over 15 years and has a high level of expertise in the diagnosis, procedural skills, management and delivery of complex fetal anomalies and gynaecological issues. So I'll hand over to Talat, it's all yours.
Thank you, Sandra, and what a pleasure it is, as always, to help be part of this amazing initiative looking after shared care shared care doctors. And I wanted us to use this opportunity to revise our protocol. And as you well know, that this is a combined protocol created between a committee that has a membership by GPs, midwives that are dedicated liaison midwives in this space, and obstetricians. So it's a combined group, and it's a really good integrated committee that creates this. So any feedback at the end regarding your own journeys is very much valued, or any specific feedback you have around patient care. So basically, as you know, the pregnancy journey starts early in your hands as general practitioners. Our first visit that is recommended is the booking visit, which is meant to be less than 10 weeks ideally, but we know that some women book later than that. And this can be spread either as a typical long visit, or sometimes some GPs prefer to do it over 2 visits. And obviously the purpose of this is to actually confirm and date the pregnancy. If they're not sure of their last menstrual period, do not have regular cycles, any concern regarding the dating of the pregnancy, and certainly in our geographical area, most women would want to have a dating scan. And this ideally should be timed at around the 8-week mark. And this is another opportunity to ask around history, any risk factors, and remember a very holistic approach in terms of do they have any depression, anxiety, and particularly in these times of the pandemic, I think it's so much more, there's so much more anxiety and mental health issues. So we've got to be mindful that a pregnancy is a time that's difficult for women and their families at the best of times sometimes. And this is not making it any easier, our general global situation. So if you look at the screen there, apart from all these life stresses, alcohol abuse, drug and alcohol, we want to make sure that we're not missing other things like cervical screening. We know that this is an opportunistic time for some women who may not be that regular with things like that, particularly women who are coming back for repeat pregnancies. It's a good opportunity to offer that and to diffuse any myth that they might have that it causes a miscarriage. And so I usually am very clear and I say, yes, there is a baseline risk of a miscarriage, but there's no evidence showing that us doing a cervical screening for you in pregnancy will increase that risk. At the same time, obviously, we need to organize the booking bloods. We know that we want to know their full blood count. In fact, their actual, specifically their hemoglobin, we're very interested in at that point to see if they need any iron support because it's low, or whether they might be of a background that might be more likely to be a thalassaemic sort of a trait that they might be having. Then we want to know that they're immune to rubella, to hepatitis B, Hep C, HIV, and our routine screening also includes an MSU and for syphilis, and very important to check their blood group and their antibody screen. We have chosen to add varicella IgG. That's not in the national guidelines, and the national guidelines basically suggest that we ask, and if there's a concrete history that the patient shares, that is enough. But we've found that as a team that it's been helpful to have their varicella immunity on board. Then we know that diabetic screening is a space that has had many changes. Our current thinking is that we want to offer hemoglobin A1C to women that are at risk. And who are these women? These women are women that are over 40. So if they have advanced maternal age, we want to screen them if they are high BMI. So if their BMI is more than 30 kilogram per meter square. We want to screen them if they're from an area that is higher risk, like for example, subcontinent origin, the Asian origin, the Middle Eastern or African origin, for example, islander indigenous population. We want to make sure that we're offering more support by trying to pick up any gestational diabetes early. Then, of course, women with polycystic ovarian syndrome or a previous GDM is a very strong risk factor for a repeat GDM or a strong family history. So that's actually a large cohort of women. And for those, we want to offer early screening. And the results are basically in a binary fashion. If they're less than 5.9, we basically say, look, all you need is the repeat, you need a OGTT at 24 to 28 weeks later on in the pregnancy. If, however, the result of hemoglobin A1C is more than 5.9, then for practical purposes, we basically triage them at the moment to our GDM clinic, whether in your geographical area you're sharing care with Nuchal Hospital or with Hornsby Hospital, please, or Northern Beaches, please triage to the appropriate hospital. Longer term, hopefully, very exciting directions may include that we roll out management of diet, controlled gestational diabetes into the community in your hands. But at the moment, we are still managing them in-house in our services. And then the genetic counseling is being offered to women above 35 years of age in the North Shore geographical area only. Otherwise, my amazing fellow speaker, Karen, is going to give us a lot of details, so I'm not going to go into any about the nuchal or the NIPT side. At this point, the other take-home message that I'd like you to do is that encourage your women to book in at 8 weeks for the 14-week booking in midwifery visit. And the reason for that is that there is actually almost like a queue, and it is good if they get in early, and then we're able to, just from a logistic side of things, that the midwives at the hospital have requested that helps them basically stage the workload in a better context. Of course, then they see you again at, after their early scan or their NIPT or whatever early testing that they may have embarked on from an aneuploidy point of view. And then we would like to see them in the antenatal clinic at the 14-week mark. Now, booking visits in the antenatal clinic are currently being done as a telehealth exercise, only because, as you well know, we're all trying to minimize face-to-face contact where possible. And so that is an extensive discussion by the midwife with the patients, and they do that at that point. When you see them after the aneuploidy testing, it's a good time to offer the influenza vaccination if that hasn't been done previously. And then the hospital basically, two different hospitals have different systems, but they triage into, yes, it's fine for GP shared care, and we get the tick, and the patient comes back to you. Sometimes the patients, as you well know, change their mind and they hold on, even if they're, the low risk women then continue care with midwives, and at times they develop risk factors and therefore need to be in the medical hospital medical model. So basically, from a GP perspective, you would then see from the 14-week mark these women 5 times on an average in their pregnancy. So that's at 20 weeks, 24 weeks, 31 weeks, 34 weeks, and 38 weeks. And these are not prescriptive. Obviously, you can have some change. Sometimes women have different circumstances, but that's what in general that we encourage. And they would be seen at the hospital end as well in between those visits. So we do the hospital end at 28 weeks to try and at that point, we want to basically give them the immunization for rhesus if they're if they're Rh negative. And the second time that we give the rhesus and immunoglobulin is when they are 36 weeks. And I know that the national protocol says 28 and 34, but we are again trying to adjust logistics to the best pattern available for majority of our patients. And then we also, when they come to us at 36 weeks in the antenatal clinic, usually seen by the liaison midwife, which is a strategy to try and enhance communication with you, that the GP workforce that we work with. Then basically at that point is a good time to do the vaginal swab, and that is tended to be encouraged to be done in the hospital end. And then after 38 weeks, which is another routine visit, you then sort of almost hand over for her 40 and 41 week to the antenatal clinic with the aim that they're going to come back to you for the postnatal service. And again, at that point, there's an opportunity to debrief around their journey in terms of at a postpartum context. We also want to check up on any cervical screening, which may be due at this point. We certainly want to talk about contraception. Australia in general has a very low uptake of LARCs, and we want to use this opportunity not to miss any patient that might be interested in long-acting reversible contraceptives. It's also pelvic floor. There's more and more emphasis on the integrity of the pelvic floor and to involve a physio in that space if there's any concerns, as well as potential to ask for any breast-related problems. As always, whilst we start our journey of pregnancy and towards the end in terms of the postnatal visit, it's an opportunity to assess their mental health, and we need to repeat the Edinburgh postnatal depression score, and of course assess the baby and see how the baby is thriving and breastfeeding and all those typical postnatal angles that we need to do. So that's our protocol. I'd like to use this opportunity now to share with you a video, and that is just highlighting the value of fundal height. So we start measuring fundal height at around 24 to 26 weeks of gestation. And I've just recorded, with permission from my patient, a video to help share, just remind us all about the fundal height angles in the antenatal care that we provide. Thank you, Judy.
Okay.
Okay, hi, this is one of our lovely women, and we'd like to do a fundal height demonstration today. Fundal height is done after 24 weeks of pregnancy because the uterus is high enough in the, expected to be high enough in the abdomen by then. And basically it is from the top of the uterus to a fixed point, which is the anterior part of the pubic symphysis. So the way I do this is that I do turn the tape measure around, and in times of COVID particularly, we're trying to use one tape measure per patient, which is a disposable one after cleaning our hands and getting permission from our patients. So use the curve of your hand to get the top of the uterine fundus, and then all the way to the fixed bony point in front of the pubic symphysis. And I tend to do that blind so that we can, so fundal height measurement is a way of checking indirectly the growth of the baby and the amount of water around the baby. And so we do this out to 24 weeks regularly during every antenatal visit. And the first thing to define is where the top of the uterus is. And so, Alex, do you mind bringing it closer just to, that's the variable point. And then I tend to use the tape measure upside down until the fixed point, which is actually with the top of the front of the bony part of the pubic symphysis. And then that basically tells us how many centimeters we're looking at, 29 centimeters. Okay, so that's the fundal height measurement. Again, I tend to do it upside down or basically with the actual measurements concealed, because I think it minimizes any chance of bias whilst you're measuring it. Find the top of the uterine fundus, use that to use the variable point, take it to the fixed point, and then that's your measurement.
Thank you. And I'd just like to share that, you know, if it's more than 3 centimeters out, typically, then or less than 3 centimeters expected. So for example, let's say she's 34 weeks and it's less than 31 centimeters, or it's more than 37 centimeters, then we need to organize an ultrasound. We need to ask what is going on. Is it larger because there's a large baby on board? Have we checked our dates properly? Is there too much lico? You know, is there a fibroid or a large ovarian cyst in mom's tummy? Or is the BMI really high of mom? And so therefore we're getting these high values. And we need to sort of investigate and question why it's so high. And similarly, on the other hand, you know, is there less lico? Has she broken her waters? Is the baby really tiny or small and not well grown and having some IUGR on board, or small for gestational age baby? Or is this, you know, we need to sort of ask why there's that discrepancy and organize an ultrasound or the needed investigations at that point. The only one other thing I please wanted to mention was around pertussis vaccination. So our vaccinations are so important, and they're literally in your hands to help women and encourage women to take them up during pregnancy. So it's mostly in a third trimester. It's basically between 20 and 32 weeks. We try to encourage you to give it closer to the 32-week mark and only give it earlier in women who are high risk of preterm birth. We obviously in those women don't want to miss the opportunity to give them the pertussis, but it's unlikely, obviously, if someone has had a significantly early preterm birth, she would most likely be in a medical clinic. But that's the rationale between that wide window that we have for giving pertussis vaccines. Thank you for your attention. I'll hand over to Karen at this point.
Thanks, Talat.
Thank you.
So I'm just going to share my screen if I can. And then hopefully 2 other consultants from MFM at North Shore will join us. And feel free to just fire away with the question. I have no problem if you unmute if I don't happen to notice the comment come through on the chat. But it's always much nicer if this turns into more of a discussion rather than me talking at you. So what I've done is I am hopefully going to be joined by Margie Harpham and Catherine Austin. They're 2 of my fellow maternal fetal medicine consultants that are working at North Shore. They've both just recently come back from maternity leave, so they're super keen. They are also hoping to start private practice. So if you have some high-risk patients that you feel would benefit from maternal fetal medicine care, I'm sure they'd be happy to hear from you. Between the 3 of us, we At least one of us will be in the department 5 days a week. I'm more than happy if you want to call if you need some advice. So what I've tried to do is turn the discussion today into 6 cases that will cover a variety of issues, just so that we can cover all permutations. So case 1, let's just move straight on to it. If I can get my mouse to move to the next slide. There we go. So case 1 is, we have a 42-year-old lady. This is a spontaneous pregnancy. It's her first pregnancy and she's 10 weeks gestation. There's no family or personal history of concern, but she wants to know as much as she can. So just quickly look at what that question is. A couple of questions for Talat. So what can we screen for in early pregnancy? So there's 5 general areas. 1 is common aneuploidies. 2nd is structural anomalies. So how is the fetus forming its organs? 3 is complications in later pregnancy. 4 is less common aneuploidies and microdeletions. And 5 is genetic carrier status. So we're going to go through each of those 5. So common aneuploidies. So your common aneuploidies are trisomy 21, 18 and 13. Followed closely by the sex chromosome issues. Now trisomy 13, 18 and 21 does increase with age. So for our 42-year-old, she probably has about a 1 in 80 chance of this fetus having trisomy 21. There are a few other chromosome issues that don't change with age. So for example, Turner's syndrome, so XO and triploidy. So we need to think of the things that are age-related and non-age related. So what are her options? Number 1, she could choose to do no screening, and that's perfectly acceptable if the result's not going to change her wishes.
You've frozen, Karen.
Karen, we can't see you or hear you. Sandra, should we ring her?
I'm back.
Hearing it.
What I'm going to do is I'm just going to turn off my video just because that's probably slowing the speed of the presentation down, and see if that makes a difference. So let's go back to where we were. So nuchal is designed for as many factors to be included in the program as you can get. So if you included all of the ultrasound factors, including nasal bone, ductus venosus, and the serum into that program, then the detection rate for Down syndrome is 90 to 95%, which means that 90 to 95% of fetuses are going to be in the high risk group, which is any figure from 1 in 2 to 1 in 300. Now, if our patient who is 42, if our patient who is 42, have you guys still got me? Just checking that you've still got me. Okay, I'm going to leave it off. Yeah.
Without your video, we can't see your slides.
Okay.
Got your presentation, I could share it for you, or she could.
Yep, either way, I don't mind. Do you want to try that? Let me try sharing one more time. If it drops out again, then let's just forget about it. what I'm going to do is leave it in non-presentation mode in case that helps. Yeah? You still got me?
Yeah, yeah.
Okay. So if we include nuchal, serum, nasal bone and ductus venosus in the program, we're going to detect probably 95% of fetuses. So that means that 95% of all Down syndrome babies are going to be in our high risk group, which is a number of 1 in 2 to 1 in 300. So that also means that we've put a lot of normal babies in that high risk group. So approximately 5% of normal babies will also be screened into numbers of 1 in 2 to 1 in 300. For our 42-year-old lady, because she's already starting from a risk of 1 in 80, it's going to be reasonably difficult to cross her over into the low risk group. She will have to have pristine factors in terms of nuchal, serum, nasal bone must be clear. The difficulty for you guys is that somebody can generate a report out there in radiology community land and say the nasal bone is present, but it doesn't necessarily mean they have it unlocked in the program. So they can say anything they like on the report, but it doesn't necessarily mean that it has influenced the nuchal risk assessment that you are given, and that gets really confusing. Without nasal bone unlocked in the program, the best they can get is a 10-fold drop from the background risk. So they're seriously limiting the number that this patient can generate as a risk assessment. So that makes it difficult. So her other option would be to do cell-free fetal DNA. So we know that little fragments from the placenta will then break off and then go into mum's circulation. They are fragments from the trophoblast. The trophoblast is the highly repetitive active tissue of the placenta. So it makes sense that because it's going through so many cycles of cell division and replication, that those fragments are going to make it to mum's circulation. Now, this calculation has got nothing to do with age. So it hasn't got a predetermined background risk that it's influenced by. It is literally saying how many fragments for the chromosomes that I'm interested in can I find. So it is much more sensitive. So if you are low risk, that's great. Yeah, it will detect 99% of babies with Down syndrome. So therefore, if you are high risk, somewhere in that high risk group, you have included the majority of babies with Down syndrome. Where age is going to influence her risk is if she generates a high risk result, because now you're asking a completely different question. What you're now saying is that if she is high risk, what's the chances that it's real and it's not a false positive, it's not an overcall from the lab? And that's where age will influence her results. So it doesn't influence her chance of getting a high result, but it does influence the chance that it's real if she generates one. But if it's low risk, it is very reassuring, and her risk is probably somewhere close to 1 in 10,000, although the labs have stopped putting those sort of numbers on the report. In terms of your other common chromosome issues, in terms of a NIPT test, it is highly sensitive for trisomy 18 and 13 as well, but it's not quite as good as it is for trisomy 21. That's what it's been developed for. The beauty of the nuchal, however, is that at the time where you're measuring the nuchal thickness, you have the ability to look at the fetus in other ways, which you can't do if you're doing cell-free fetal DNA. So to generate a nuchal number, all you actually need is the crown rump length, the heart rate, because that influences your trisomy 13 risk, and the size of the nuchal. Then you add that in with mum's age and serum. At that time, though, you've got the ability to assess for other structural issues in bub and for maybe some hints about other things that we should be concerned about. So the trade-off is that you can get more information at the time of the nuchal than what you're generating from just a sample of mum's blood. The other thing with the NIPT test is you can turn up to Douglas Anley Moyer with a form and they will collect it. But approximately 3 to 5% of all women will actually have a miscarriage on board. And it's a very expensive test to find out that you've got aneuploidy for a miscarriage. So I would highly recommend that you either do a late dating scan or a review within the week that you're doing the NIPT prior to the collection, to check that, number one, you've got one fetus on board, it's not twins, because that's going to alter what the lab's going to analyse. Number two, the fetus is alive. And number three, there's nothing significant that's going to say NIPT is not for this patient. So I don't know if we've got Kath or Margie on yet. Doesn't sound like it. So, sorry?
I saw her come on briefly.
Okay. So when I was talking about what else you can determine at the time of the nuchal translucency in itself is wonderful information, because the thicker the nuchal is, the more likely you are to find a chromosome defect, the more likely the fetus is at risk of fetal death in utero, the more likely you're going to find a major structural anomaly, and the less likely that this baby will be born alive and well. Have you still got me?
Oh.
Yep.
You're happy, Karen, yes.
Yeah, good. So if you have a low risk NIPT, a nuchal translucency measurement of 3.5 or less is considered normal range. So if you get a nuchal, anything 3.4, 3.2, that is considered normal, and we would not encourage any further testing. If, however, you are working on just a nuchal translucency, anything that is more than 3 deserves a discussion to make sure that there's nothing else going on. Ah, there's Kath. Kath's on mute too. No, Kath's there. Kath, we're just talking about nuchal translucencies.
Thanks, Karen. I've just joined, so fantastic.
So we're just talking about the thicker the nuchal, the more likely you are to find an explanation for the thickness of the nuchal, and the more likely you are to have an adverse pregnancy outcome. So if you are doing NIPT, the nuchal measurement is still important, because we know that if it's more than 3.5, we're going to think of other issues that we want to think about: structural problems, risk of fetal death in utero, or maybe other chromosome issues apart from the common chromosome issues, so apart from 21, 18 and 13. So even if you've had an NIPT, even though we know that's highly sensitive for trisomy 21, 18, 13 and maybe the sex chromosome issues, it is still worth doing the structural scan at about the same time that you do the nuchal, because you will get more information on, number one, the structure of this fetus, and number two, you are then doing a screening test for less common issues that could be present in your fetus. The other information that is possible to get, even if you've done NIPT, is the serum component for the nuchal. Now, I'm not suggesting that you go and do a nuchal translucency screen on top, but I am suggesting that you should think about adding on PAPA, PLGF and beta-HCG. Any thoughts, Kath?
Yeah, thanks, Karen. Can you guys hear me? Is that coming through now? Fantastic. So we absolutely agree. Look, certainly I think the world is changing with regards to where we're going with NIPT, and in some ways the devolution of the nuchal translucency scan as we know it. But we absolutely agree that the PAPA and PLGF, as well as beta-HCG, do just offer those a little bit of additional information. So really around underlying placentation, and as Karen has mentioned in this slide, looking at certainly the fetal growth restriction, fetal demise, preterm birth and preeclampsia, but then also more particularly, some of the cases I've been more involved with is when we do see the PAPA of less than 0.2, starting to think about, well, is there another underlying chromosome association that, as we said previously, is different from the standard 13, 18, 21? And the same sort of information when we look at the high and low beta-HCG levels. So I think absolutely that these do still offer quite a good amount of information, and certainly something that does help us when they come for a counselling perspective, to really start to guide our patients in giving them the most information we can at this point in time.
So certainly the extremes of your serum factors, it is worth considering sending them for a discussion in regards to additional diagnostic testing. So a PAPA of less than 0.2, there's a 4% risk of finding an atypical chromosome or copy number variant. and either very low or very high HCG levels. So there is value in them. Going back to NIPTs, I just want to make one comment that not all NIPTs are the same. So there are basically two different platforms that you can use for an NIPT test. One is targeted technologies, which the famous Harmony test is a big proponent and verifying. Harmony are fantastic marketers, and it is amazing how often I hear people talk of the Harmony test rather than cell-free fetal DNA or NIPT testing. So they have become almost as, in our language, as Google. So it is very frustrating, but of all of the companies, they are quite limited in the information that they are giving you. They are a targeted technology. So Harmony I consider is the cheap and cheerful NIPT. What they do is in that sample of maternal blood, they pick out the little fragments because fetal DNA is often smaller than maternal DNA. So they pick out the DNA that's only 100, 200 base pairs, and they assume that it's fetal. They then try and map it to the chromosome or even the subchromosome component that they're interested in, which is why they can do a 22q on top. Anything that doesn't fit into their bucket, they chuck out. So they only analyse a small percentage of all the DNA that was originally in that sample. So they are limited in what they can tell you. They have a couple of other chromosomes because you've got to have a reference somewhere, yeah? But it is limited information, and every time they develop their test, for example, when they developed for 22q, they had to go back to the drawing board and develop a new bucket of information to keep, yeah? As such, you can imagine that they've got the highest inconclusive rate, and they're missing a lot of genetic material that may have actually helped them interpret some of these inconclusive tests. So what they then do is, based on this limited information, is they then pick out some maternal fragments and then they basically stick it through a great big PCR machine. If they started with 5% of the fragments were from the fetus and 95% was from mum, they expect once they've PCR'd it within an inch of its life that they still will have 5% from the fetus and 95% from mum. If, however, there was a bit more genetic material initially from one chromosome, so let's pick chromosome 21, you will then find after you've PCR'd it that that percentage will change slightly. So you may end up with 6% from trisomy in chromosome 21 in bub and 94% from mum. And it is that change that then makes them assume that therefore we must have had 3 copies of the chromosome in the beginning because that's how we ended up with more fragments. So another way that we can have a bit of an error. Now, don't get me wrong, it is a great test and it's very sensitive for trisomy 21, but just beware. The other thing to beware of is in their reports, if they get a result for anything, they generate a report, but read the report carefully. I cannot tell you how many times I've seen a report where they go low risk trisomy 21, low risk trisomy 18, low risk trisomy 13, sex chromosomes unreportable. Well, that's an inconclusive. But they will have charged the patient, they generate a report, read the report carefully. Because there is sometimes a report where they haven't got a result and that's concerning. Your other platform is massive parallel sequencing. Every fragment they get from that fetus, they map somewhere. So they have all 23 pairs of chromosomes buckets filled. So if they wish to expand their test and look at more sort of smaller fragments or deletions or duplications or at a different chromosome, they just have to flick the switch in what they're reporting. So their inconclusive rates for the companies that use massive parallel sequencing is much less than for Harmony, and they will find things that Harmony or the counting methods will miss. Trade-off is they may find something that you weren't expecting, and therefore it's important that you counsel your patients that we are potentially looking at things behind the scenes that you weren't expecting, and they may generate a high result which may need further clarification and testing beyond something that you were thinking about on the report. Sex chromosome aneuploidy we know is present in all of these reports, but it is something that you seriously need to think, have I counselled my patient appropriately? Because number one, they're different to Down syndrome, trisomy 18 and 13. It is highly unlikely to be associated with significant developmental effects like the other three autosomal trisomies. And most of the effect for these fetuses is really infertility. And it is important that in your pre-test counselling that you make this clear to patients that they're generating this information, because it is very difficult once you've generated a high risk result for a sex chromosome aneuploidy to then go back and discuss this. So what else can we screen for? So structural anomalies is one thing. So as I was saying, an NIPT by itself is not good enough. Screening for how the fetus is forming its organs is equally important, and that can be done at the same time as the nuchal. But it requires an additional screen for the woman who decides to have NIPT. Margie, any comment?
Yeah, I can't back that up strongly enough, Karen. We certainly see women who have gone for their NIPT and they've paid for it and they've got a nice low risk result, and then they come for a morphology scan and you see something majorly structurally wrong with the baby that would have certainly been detectable early on. You know, in the pictures that you've got there, you've got some beautiful examples. An anencephalic baby that would have been picked up early on. You've got
and interestingly, Margie, that anencephalic baby, this is a 10-week scan. So that would have been detected at a scan just prior to NIPT if you had done one. Yeah.
And I mean, NIPT is an amazing test, but it's a very limited test. And I mean, the other examples you've got the triploid baby. This is a condition that is very poorly detected by NIPT, or not detected by
regardless of your platform, triploidy is really difficult for NIPT to detect. Because every chromosome is going to have extra amount, so they're never going to see a difference in anything. Yeah. So you can appreciate why they're likely to miss triploidy unless you're looking at SNP. So unless you're looking at single DNA variations in your base pairs, you're not going to find it.
And I think, Karen, we have to remember that couples come worried about Down syndrome. They're worried, you know, I want to make sure everything's okay for my baby, it doesn't have Down syndrome, but actually what they're saying is I want to make sure my baby doesn't have a major problem. And we can help with that in other ways.
And up to 70% of all structural anomalies can be detected at the time of a nuchal or an early structural scan. So a scan somewhere from 12 or closer to 13 weeks would be my preference, only because the detail that you can see in the heart is significantly increased at 13 weeks. But somewhere between 12, 13 and even 15 weeks, there is a good chance if there's something major, we're going to see it. So what else can we screen for our 42-year-old lady? Well, certainly complications in later pregnancy. And I know this is Kath Austin's little baby.
Yeah, it is. Thank you very much, Karen. When Karen, Margie and I were talking about this in clinic today, it's ironic because we're obviously running a sort of high-risk pregnancy complications clinic, and a large number of the women that we see are pre-eclamptics in the first pregnancy. So this obviously rings close to our heart. But interestingly, when we see them, it's often, you know, too late for us to do things other than simply treat the problem in front of us. But certainly looking back on this, what I think, and Karen will explain as she talks through this slide, but is certainly really just thinking about what can we do at these early stages of pregnancy to think forward about what might happen for my patient in the pregnancy. And that's certainly where we, you know, have huge respect for the general practitioner who knows so much about the roles of family history, obviously what other medical comorbidities these women have, and has such great information that they can really access at these early stages. And to be honest, really in lots of ways prevent a large number of these complications. So certainly, and Karen will go through this, we look at the options of screening just from maternal factors. So that's taking a really good history and finding out about autoimmune disorders, age-related factors, history of preeclampsia, family history of preeclampsia, but also then sort of starting to dig down in this algorithm a little bit more about, we do the family history and the maternal history, but let's start to also look at what other ultrasound factors we can do. And there's lots of controversy out there at the moment, and certainly obstetric conferences that we go to internationally, and people vehemently debate, should we be screening this with ultrasound, or should we simply take a good history and talk to our patients? But I think what this really is flagging to everyone tonight, let's actually think about this as a bigger picture and saying, let's look at, if we're going to do this, let's make sure we do take a good history, or let's make sure we even think about what we can action at these very early stages of pregnancy, because in fact that's when placentation is occurring, and that's when we can actually have the most effect about reducing things like preeclampsia.
And did you get that requested, if you can make your screen full screen mode? Just so
yep. Better?
Yep.
See if I can you, yeah, okay, cool, yeah. Yeah, so if we screen just on history, we're going to get close to 60% detection of those who are going to get early preeclampsia. So I mean preeclampsia less than 34 weeks, because that's the group I'm most concerned about. They're the group where the neonates end up in the nursery, higher risk of interventricular hemorrhage, neck, needing intubation, etc. I'm not so concerned, even though I say that lightly, with the woman who gets preeclampsia later in pregnancy, because that's not such a burden to her or the fetus. It is really early preeclampsia that you're most concerned about. And as Kath alluded to, a good history will detect close to 60% of women who you should consider putting on aspirin. And there is plenty of evidence out there to say that aspirin commenced prior to 16 weeks will reduce the risk of early preeclampsia by up to 90%. So I would encourage, go for it.
Karen, just jumping in there, Karen just mentioned the dose, and we often do get asked this question. There's been a lot of discussion around what dose of aspirin do we give.
Yep.
And really the consensus is now out that 150 milligrams of aspirin for a patient taken at night time. I'm a pharmacist in a former life, and every time I say this, I have to make sure I tell women that we break the aspirin tablet in half and throw the other half away, because it turns into vinegar overnight. So if they're not doing that, they're only taking aspirin every second night, and they're taking vinegar every other night. So I think really important from a pragmatic approach. It's cheap as chips, but obviously to make sure that women are taking the correct dose, because some of the later literature coming through has suggested that lower doses that's used in the US of things like 81 milligrams don't have the same effect. So I think it is important to suggest 150 milligrams at night. Throw that half of the 300 milligrams away and just take 150 milligrams at night and prior to 16 weeks to commence that. And often, certainly in the public system where it's a GP shared care program, women haven't necessarily seen an obstetrician at that point. So that's where we really do rely on the general practitioners to kind of help us out with this and make sure that we do get them started at that early stage.
Kath and Maggie, I'm just going to rely on you guys to just look at the questions and the comments coming through, because it's just slowing my internet down if I do. You will see that a number of ultrasound practices, though, will screen for preeclampsia at the same time as a nuchal or structural scan. And that is because if you add ultrasound factors and maternal blood pressure into the calculation, you're going to improve your detection to 90%. So you will see plenty of reports coming out. It is suggested that anybody on that screen who has a risk of greater than 1 in 100 should be placed on aspirin. And there is plenty of pockets in Sydney who are great believers in the nuchal or the preeclampsia risk calculation at the time of the nuchal or the structural scan. So you will find certain area health services suggest that all their women should undertake screening. We're not quite all on the same page in northern Sydney, but we're working on it. So what about the uncommon or the less common aneuploidies and the microdeletions? So we've gone through chromosome 21, 18, 13, X and Y, but there's a bunch of other genetic material that can be looked at. So one of the first panels that you would have seen being released is the microdeletion program. Again, the company, which is Panorama, that released this panel, really thought about what they included on the panel, because all of the issues that are on their panel are all unrelated to age. So it means that they can market it to every pregnant woman out there, not just necessarily those of advanced maternal age. If you look them up as a patient, everything bar 22q, you would read about Angelman and Creedashar and Prader-Willi and go, oh my God, I wish to screen for this, because the outcome is pretty awful. And from an ultrasound perspective, most of them are not going to show you any markers on ultrasound unless you pick up probable late growth restriction. So then you're dealing with a fetus in the 3rd trimester rather than the 1st or the 2nd. The difficulty with the microdeletion panel is we've now marketed it to women, but the incidence of those conditions is really quite low. 22q is the most common at about 1 in 3,000, but it only picks up 75% of 22q deletions. So it's not considered specific enough to be a diagnostic test, and there's 25% that you will not detect with this microdeletion panel. The rest, Angelman, Prader-Willi, Cree-Duchar, the incidence of those syndromes is so low that most often, if somebody generates a high-risk result, it's probably a false positive. So even in their own reports, you will see that the positive predictive value, if you've got a high-risk result, is extremely poor. And even when it comes to something like 22q, which is the most common of the lot, really there's only a 5% chance that you're going to actually have a bubby that's got 22q if you've got a high-risk result. Great if you've got a low-risk result, you've probably reduced your risk, but a high-risk result nearly always is a false positive for those conditions. So I'm not saying don't do the microdeletion panel, but I think it's really important that you go into the test with your eyes open and you clearly point out to your patients that if it's low risk, that's reassuring, but if it's high risk, chances are this is probably an overcall, but then I am going to need to do diagnostic testing to rule this out. And I can tell you from experience, the diagnostic testing takes you up to 6 weeks to get back, and that's a really long time. So then we move on to the rarer autosomal trisomies, or colloquially get called as RATs in the genetic field. So 21, 18, 13, X and Y account for about 75% of all of the trisomies, but there's 25% that will not be detected on your normal NIPT. So that's a lot of information that could potentially be important. So you will see that there are some organisations that are reporting whole chromosome aneuploidy, i.e. I'm going to give you a risk assessment on all 23 pairs of chromosomes. So that is that whole genome-wide spectrum, which is the second method in our NIPT that we were looking at. If you look at all women who undergo NIPT testing and you look at whole genome chromosome analysis, 1 in 300 will actually be high risk for a RAT, or a rare autosomal trisomy. And it's not anything to be sneezed at. So roughly 30% of them will either have an adverse pregnancy outcome, and up to 20% may have fetal death in utero. So if you've detected on NIPT that you've got 3 copies of one of these RATs, then there's a couple of incidents that could have happened. Number one, it's either in the placenta, and so therefore we've got an increased risk of placental issues. So that includes growth restriction, fetal death in utero, preterm labour, and the chromosomes that are more likely to be associated with placental issues is 2, 16 and 22. The other thing that could have happened is if we've got a trisomy in our placenta, what has our fetus got? So a lot of these rare autosomal trisomies, if the fetus actually did have full-on trisomy, they often end in a miscarriage or fetal death in utero. So that's not the group I'm worried about. But what about the fetus who then has either a mosaic result rather than a full-on trisomy? Some of these rare autosomal trisomies, when they are a mosaic picture, are associated with awful outcomes in terms of intellect and outcomes for these fetuses. So they're a group that I'm concerned about. The other scenario that can happen is you've got 3 copies in your placenta, so you've got a trisomy. In the fetus, if it doesn't inherit all 3 and it has a trisomic rescue, what it does is it tries to get rid of 1 copy of the chromosome. So it will try and go down to 2, so it'll try and go back to diploid. The problem is you don't know which copy of that chromosome this fetus rejects, and if it loses 1 copy, let's say it's got 2 copies from mum and 1 copy from dad. If it loses the copy from dad and you're only left with 2 copies from the same parent, then that has issues when it's associated with certain chromosomes. So there are a group of chromosomes, in particular 15 and 16 are common ones, whereby if you inherit 2 copies from the one parent, it can be associated with a chromosome, for example, Angelman. So there are some chromosomes where it is way more important when you detect a rat that you need to do more extensive testing than just a karyotype, because proving your fetus has 2 copies is not good enough. This baby needs UPD studies depending on the chromosome of interest. So these rare autosomal trisomies, there is immense evidence coming out to suggest that they are important. And even though individually they're rare, you add them up and 1 in 300 women will be high risk and actually have one of these going on in their placenta, plus or minus some issues for their fetus. So what else can we screen for now that we've scared her?
She doesn't want a pregnancy anymore.
No, she does. She just wants a really good NIPT and a structural scan, and she wants some aspirin because she's going to be high risk for preeclampsia.
That's right. Start the aspirin.
So the other thing we're going to offer her screening for is genetic carrier status. So RANZCOG last year changed their statement to suggest that all women should be offered screening for genetic carrier status. And that's because there are some things that are common. So we have 3 ways of screening. We can either screen for common things, i.e. something that's of similar incidence to trisomy 21, or we can screen based on ethnicity, or we can do an expanded let's cover all bases panel. So if we start simple, yeah? So in terms of genetic carrier screening, if we screen for the most common conditions, 5% of women will come back as carriers for one of the 3 disorders, which is, where's my slide? There it is. Cystic fibrosis, spinal muscular atrophy. Is this in the way? Can you see my little window that pops up with your faces here? Is that a no from you guys?
We can see it.
Yeah, okay.
Yep.
So the incidence of cystic fibrosis in the Caucasian community is about 1 in 25 to 1 in 35. Spinal muscular atrophy is 1 in 50, and Fragile X is 1 in approximately 30. So if you add up the incidence of those, it's probably just as important as trisomy 21 to this woman. So it makes sense to think of testing for common things. So this is actually pretty easy and quick to test for. 90% of carriers have no family history. So relying on her history is not good enough. So you can see why the college has changed the statements from may be offered to should be offered. Secondly, the cost of these tests has come down remarkably. So you can do these 3 for less than $100. And it's not going to change. Whatever she carries, she is. This isn't going to change with age. You only got to do it once for her. It's just sad that she's 42 and this is the first time we're seeing her. So why do we want to screen for these things? Number one, we can diagnose them. We can do a CVS or a diagnostic test to see if the fetus is affected. If she chooses to continue or have no testing, we can offer early treatment, which will affect life and quality of life. Or maybe we want to think of doing other things. Maybe not necessarily saying for our 42-year-old who's conceived, but maybe she wants to consider IVF or a donor of some description that doesn't carry whatever our issue is. And remembering we're screening for recessive disorders. So if they're both carriers for, let's say, cystic fibrosis, there's a 1 in 4 chance that this fetus could be affected. There's a 50% chance that the fetus will be a carrier similar to the parents. And then there's a 25% that the chance that the fetus will get nothing. So 25% chance of this fetus being affected if both mum and dad carry cystic fibrosis is pretty significant and probably more important to this woman than Down syndrome. Points to note with genetic carrier screening though. Ideally, it would have been nice to see this woman prior to her being pregnant, because we've now got reduced time in order to get these results, and some of the panels can take up to 6 weeks to come back. Now that she's pregnant, I certainly would consider testing both her and her partner at the same time so that we can get important information about them as a couple quite quickly, rather than testing mum first, waiting for her results, and then trying to decide what we test the partner for, because that's just going to add time. It is not dependent on age, and you can collect samples with either saliva or blood, so it's fairly simple. But there's no Medicare rebate with any of the counselling or the testing that goes on for genetic carrier screening. So they need to be aware of the out-of-pocket costs. And certainly the labs are, again, and I keep going back to clever marketers, but some of the labs are very clever in saying, for one woman, we will test, let's say, an expanded carrier panel, and it's going to cost you $800. You add your partner and we'll give you a discount of 50%, or we'll do the couple for $1,000. So it's great, yeah? You get two for the price of one. Sounds a little bit like Bunnings. But consider the turnaround time and what you're testing for. Make sure you are very clear to your patients about what the potentials are in the result, because the more you test for, the more likely you are going to find that somebody carries something. So when you're doing panels of 300 or 400 genes, it is highly likely that 3 or 4 of those genes are going to come back positive in at least one of, if not both of your partners. And just remember that they will reduce your incidence of these syndromes, but they don't take the risk away completely. The third thing to note is that if you do come back as a carrier for something, then it may have implications for other members of your family, so the children that you already have or relatives. So what do some of the panels cover? Well, oh my God, you should look at the list. Half the time I don't even know what these conditions are, and I have to refer to the genetic counsellor. So they get really complex. So once you're talking 400 or 500 genes, you want to really make sure that your patient understands that there's a good chance that she's going to come back as a carrier for something, because we all will. But not all the panels are the same. So for example, most panels will not cover thalassemia. So if you have a couple that they're from a nationality that's at high risk, they still need a hemoglobin EPG, and these panels are not the be all and end all. They are all limited in what they're looking for, and even though they may say they cover the same syndrome or genetic condition, doesn't mean they're looking at the same mutation. So again, I say be careful and go into them with your eyes open. Most of these companies will have genetic counsellors that are available for advice, and I would advise you to either talk to them or to your own local genetic counsellor, because it is getting complex and there are more and more of these panels coming out, and the cost is getting cheaper all the time, which is enticing people to have the panels done. So here are just 3 examples of useful resources. Certainly, New South Wales Health has got a good number of fact sheets. So does the college and a number of the NIPT providers who also offer these panels. The other information that's worth knowing about is that there's a multi-million-dollar research project going on called Mackenzie's Mission. It started, a couple had a little girl that had spinal muscular atrophy, and it wasn't diagnosed till after birth. She survived 9 months, and it was only after birth that we discovered that both the parents were carriers for SMA, and it could have been easily detected antenatally. They then became very big proposers for genetic carrier screening testing, and they've managed to get a $3 million grant in conjunction with New South Wales, or I think it's even Australia-wide health, to try and look at couples and do genetic carrier screening. And one of the labs that's offering it is SEAL, so it's Southeastern Area Health Service. You do need to check out the website though, because they're not accepting all couples, but they do have funding to allow for even cycles of IVF for couples that are both found to be carriers of a condition that wish to go down that path. I'm going to skip this slide. Are you happy if we go on to case 2, or is there any questions that anyone wants to raise on our 42-year-old?
Karen, just on the chat at the moment, there's a number of questions just really around companies that I think you're probably best versed to answer at the moment. So I might just let you have a read of those. We've been trying to answer as you go otherwise. But
my problem is I can't see the chat with screen share.
So the question is about which companies do the Illumina platform predominantly?
So VCGS, Lavity, in fact, Lavity, I think either this week or last week have changed their reports, and they do have an option for, I think it's called Gen 46 is their extended panel that does whole genome screening. And they're probably the two big ones. Panorama also does a whole genome screening, but they use a different technology, yet they use SNP. So probably those three are the sort of most extensive analysis that you're going to get at the moment. Whereas Douglas Hanly Moir is Verify, which uses specific fragments, so it's Harmony-based platform.
And then the other question following that was, does it cost more than SNP?
Yeah, so for Lavity, using the Illumina 2 platform on their Gen 46, I think is the name that they're going to use in their marketing, it is unchanged. VCGS, usually it's about a $50 increase compared to just the usual $21, $18, $13 cost. So from private practice perspective, because open disclosure, I work at Ultrasound Care, VCGS testing we charge $4.95, Lavity we charge $4.45, so it's a $50 difference.
Yeah, I think they were the main types of questions at this stage.
Mm-hmm. Yeah, and you will find more and more companies go to the whole genome screening, whole chromosome screening over time, because they're going to want to offer the expanded panel, because there is certainly evidence coming out to suggest that it is important, and they are detecting not only mosaic fetal stuff, but confined placental mosaicism has its own risks associated with it, and it should not be ignored.
Great.
Okay, so case 2. So case 2 is a young woman who ends up having a high-risk cell-free fetal DNA result for trisomy 18. So she's about 30-something. She goes for IVF. As you do for IVF, once you've conceived, they say, please have this U-Butte panel, including the microdeletions. It's only a mere $750 more. And once you've put your credit card in your hand for everything else for IVF, it seems like a good idea. So interestingly, the microdeletion panel comes back low risk, but she's high risk for trisomy 18. We've got a decent fetal fraction, so you probably can't read it, but that's 9.7%, and she's about 12 weeks. So that seems like quite a reasonable result. So the first thing we will do for her is look at the fetus on scan, because this fetus looks completely normal. So the crown rump length is appropriate for the gestational age. There's a lovely thin nuchal. One of the most common things that you will see for trisomy 18 is, I like to look at hands. Hands are a giveaway. Most babies with trisomy 18 have quite tight tendons in their fingers, and so they have clenched hands, and it's one of the most common things that you will see with them. But this little fetus, you can see the little digits are all spread out nicely. So there's absolutely nothing that we can see on this fetus. Trisomy 18 babies are not sneaky. Trisomy 18 babies, unless they've got mosaicism, will show you multiple structural problems at the structural scan. So by 12 weeks, we should be seeing something. So this is the first thing that makes me go, okay, so we need to think about whether this is a true result or not. So in terms of diagnostic testing, I'm going to suggest to her that she waits for an amnio. Because if we do a CVS, we know that the DNA from the cell-free DNA is picking up trophoblast fragments, and so will a CVS. So if we do a CVS, we're likely just to duplicate the same result that we're getting from the NIPT, but it does not tell me that the fetus is actually affected. So I encourage her to wait for an amnio, so to wait for 3 weeks. Unfortunately, she doesn't want to. So firstly, why can cell-free fetal DNA results be confusing? Number one, there could have been a demised twin. This was an IVF pregnancy. What's to say that they didn't put 2 embryos back and that we just didn't see the gestational sac of the demised twin? Perhaps this is something confined to the placenta, so we perhaps don't want to do a diagnostic test on the placenta, or perhaps there's something in the background going on for mum that's trying to throw up a false positive result. So confined placental mosaicism the incidence does change based on the chromosome that you're looking at. So trisomy 21, there's only a 2% chance of confined placental mosaicism, but for trisomy 18, it increases to 4%. Trisomy 13, it's up to 20%. And when you start talking the sex chromosome issues that have got to do with chromosome X, it can be as high as 50%. So there's probably a decent chance that this could be confined to the placenta, with considering trisomy 18 is our high-risk result. So I suppose my little visual is just to give you the idea about why that might be. So if you're a fertilised little embryo and you start off with one cell that copies itself to go to 2 and then goes to 4, and the mistake happens very early on in this process, then every cell will be affected. If, however, you're merrily going ahead and copying yourself, the first thing that happens is you'll form your gestation sac and your fetus. And so the gestation sac, which then has the rim of the placenta, is rapidly dividing, undergoing millions and millions of replications. If that mistake happens after that division, then the fetus may not be affected. If, however, the mistake happens in one cell, which then doubles itself to 2 and one goes each direction, well, maybe the placenta and the fetus will be affected, but to varying degrees. So the percentage in the placenta may not match the percentage in the fetus. So the next thing we can do is go to one of the calculators that you can get online, which will then calculate a chance that your woman has a true result. So this is one of my favourite calculators because it's nice and easy to use, so genetic counsellors, and you can change the sensitivity and the specificity based on the actual condition or the lab test that you're using. You don't have to use what they've put in. So for our woman who is 35, the chances that this is a true result is 39%. The chances that it's a false result or confined to the placenta is 61%. So that's adding weight to my normal looking fetus for me to suggest that she waits for an amnio rather than jumping in and doing a CVS. Unfortunately, I can't convince her. So she elects to have a CVS. And lo and behold, the fast result shows 3 copies of chromosome 18. Of course, because your fast result on your CVS, whether that be DNA PCR or FISH, is looking at fragments from the cytotrophoblast. It is not looking at the mesenchyme, which is the more stable matrix of the placenta. That's going to show up in your final result, yeah, when you actually do your carrier type, yeah. So fast result comes back abnormal, and I say, please, I cannot stress enough that this is just what I expected and we should wait for more information. So then the final result for the CVS suggests that there may be a mosaic result. So I convince her to do an amnio at 15 weeks, and lo and behold, our fetus is diploid. So the fetus is not affected. But because our placenta has confirmed that we have confined placental mosaicism, we do periodic growth scans because we know that confined placental mosaicism can affect fetal growth, particularly in the 3rd trimester, but she ends up with a healthy little girl at 34 weeks. She just put herself at risk of doing 2 diagnostic tests. But a good outcome. Any question about case 2? Cool.
I'm just reading the chat here, Karen. Let's just make sure. I'll just read here. So it says we've got a positive, the PPV for the trisomy 18 is 39%, but this percentage could be affected by other factors, couldn't it?
Yes.
E.g. example, previous trisomy 18 or other factors.
So a previous trisomy 18 only increases your risk about 0.2 to 0.4%. So it's a really small change in your risk. Your bigger risk is your age. The thing that most affects the influence, I think, is looking at the fetus. Because if this fetus showed me multiple signs of trisomy 18, I'm not going to wait for an amnio. There's no point. I am just going to do a diagnostic test so that I can get enough information to allow termination in the public sector. Yeah, because you have signs in your fetus. So if your CVS comes back positive, which it will do, then it doesn't matter if the fetus is mosaic or not, it's got signs. So there must be at least some cells in the fetus that's affected. So the most important factor really is, what does the baby look like on scan? Yeah?
No more questions.
Cool. Okay, case 3. So case 3 is a 31-year-old lady, spontaneous pregnancy. First pregnancy, she opts for nuchal translucency, and she ends up with an increased risk of trisomy 21. So the first thing we're going to do is look at the factors that go into it. Kath or Margie, can you just have a talk for a second while I have a sip of water?
Sure. So when you get your nuchal translucency result back, the thing is age. As we get older, as you understand, the risk of trisomy 21 gets higher. The second thing is the nuchal translucency measurement. As Karen already mentioned earlier, that's important because it's a structural something you can see in the baby. That increases the chance of chromosomal problems, but also may give you a clue to something non-chromosomal, for example, a major cardiac defect. The third is your two proteins that come from the placenta. And then the fourth is what else you can see in the baby. Can you see a nasal bone? Can you see any other structural anomalies? And it's really important because you go down a different path depending on which of those factors gives you the high risk result. Where should we head to next? Should we do a test? Should we not do a test? Where are we going to go?
Yeah. So our nuchal is 4.9. So we've already said that when you're doing nuchal translucency screening, we're going to raise an eyebrow of anything that's over 3. When it's over 3.5, both eyebrows are raised. So it's already 4.9. So if we go back to our table, there's probably about, just off the top of my head, about a 30% chance that we're going to find something in this fetus. Yeah, but there's a 70% chance, or roughly, that this baby is actually going to be perfectly normal. So a thick nuchal is not a given that there's an issue. Yeah. Looking at the individual factors, our HCG is not particularly high or low. It's not less than 0.2 and it's not greater than 0.5. So we're not concerned about that. And our PAPA is not particularly low, at 0.7. The thing that's probably thrown out the calculation for this woman is 2 factors. Number 1, the nuchal's over 3.5, so automatically she'll be high risk. The second thing in the factor for the trisomy 21 risk is this disparity between the PAPA and the HCG. So in the nuchal program, it's looking, regardless of what your PAPA is, if your beta HCG is about 2.5 to 3 times that, then it's going to really increase your trisomy 21 risk. So it's got about a 2-fold difference. So you couple that with the nuchal measurement and it will have given her quite a high risk on the nuchal translucency. Even though the nasal bone is present, that would protect it a little bit. So it's probably partly nuchal, partly that sort of pattern that we're seeing in the serum. Whereas if it was a trisomy 18 or 13 pattern in the serum, both those values would be low. So first thing we do is look at our baby on scan. So although the nuchal is thick, we can't see any markers of the common trisomy. So there's no hints of trisomy 21, 18 or 13 based on the structure of this fetus. But and that was just going through what I would suggest we do. But she still has an increased risk, yeah? So we suggest that she goes on and have diagnostic testing. So on a CVS, she has mosaic trisomy 2 with, does it tell me? So the fish comes back normal, but there's a gain in 20% of the cells. So 20% show an extra copy of trisomy 2. So trisomy 2 has got significant implications for this fetus, but again, we've done a CVS and that does not tell us whether or not this is confined to the placenta or not. So we then have to back it up with an amnio. So our amnio then confirms that this fetus has trisomy 2, but it also, because of that, we've done maternal and paternal bloods, and we've now also uncovered that dad has a deletion on chromosome 16 in 16p11. So now we've got a copy variant, which is of uncertain significance. Any comments, Margie or Kath? Because this is a bane of our existence at the moment.
Yep, so these are the VOUS, V-O-U-S, that essentially are copy number variants that you're not usually looking for, you're not expecting to find, and you don't really know what to do with. as the technology advances, these tend to get categorized as either pathological, so they get reported in more and more fetuses or babies, adults who have problems, and you link the two together and you say, okay, we can see a pattern. Every time we see this, we see this phenotype in a baby, and then it's no longer a boost, it's a known pathological variant. Or vice versa, it gets picked up. None of us are perfect. Some people think they're pretty close, but no one is perfect. We all have very sort of genetic differences. And it may be that this is just a genetic difference that actually does not cause pathology. It just causes us to be humans that are different from one another, which I think is where we're headed. Are we with this, Karen?
Yeah. Generally, as a rough guide, I suppose, anytime you see a duplication, so you've got an extra copy of material, it's probably less significant than when you've got a deletion. So if you're missing material, it's more likely to be significant than having a duplication. However, size is important. So even quite a big duplication may have implications for how those sort of genes will work. But generally, deletions are more significant than duplications. But it just tells you that sometimes you go down a rabbit hole and you find information that you weren't expecting. So case 4. So case 4, we're going to move on to twins. So NIPT has been validated for twins, but it makes sense that monochorionic twins are going to be easier for NIPT testing compared to dichorionic, because if they're monochorionic, they should share the same genetic identity. They'd have to be pretty rare for them to not, but there are those cases. Whereas dichorionic, they're looking for 2 different genetic makeups. So it's more important that we make sure that we've got a good fetal fraction from both of the twins. But it has been validated for use in twins. It's even been validated for use in triplets, but only certain labs will do it. So in this case, we have a dichorionic twin pregnancy at 10 weeks, but we've got demise of one of the twins. So the question becomes, if we are going to do NIPT testing, when should we be doing it? So anytime you've got the death of one twin, we know that this tissue, this avascular tissue, is going to be breaking down quite rapidly. So it makes sense that you're going to get a huge increase in the fragments from the demised twin initially, and then over the next few weeks, those fragments will disappear from mum's circulation. So if we did an NIPT test today, i.e. the day we did this scan, then it may be that the fragments from this demised twin are going to overwhelm the fragments from the other twin. However, we're hoping that our lab will tell us that they've got enough material from both, and there's a few potentials that we could get from the result. So firstly, if it's high risk, is it because it's coming from the highly breaking down fragments of the placenta from our demised twin, or is it from our surviving twin? So the first thing we're going to want to do is see if we can find any structural issues with that little fetus, and if it's within range, we'll also measure a nuchal. We could think of repeating the test, because it makes sense that over time the fragments from the demised twin should change. So let's assume we then rang the lab and said, hey, just wanted to let you know that I had a demise of a second twin, which I maybe didn't realise when I sent you the first sample. We could send them another sample a few weeks down the track, maybe 4, and you could say, is the signal for this, whatever we're high risk for, changing? Is it just as strong, or is it getting weaker? And that may help you classify that. If it's low risk, then that's great, because it suggests that neither of them had aneuploidy. So we could either consider going ahead with doing the NIPT on that day, making sure that our patient understood the nuances of the results, and that we may be doing further testing if we end up with a high-risk result, whether that be a repeat NIPT, a structural scan, or diagnostic testing, because I can't tell which one it's come from. As a rough guide, if the demise happens early, then we can test earlier, because there's a really small chance that we're actually going to get a problematic result. But the later the twin demise, so i.e. if it demises at 5 to 6 weeks, if we collect a sample at 11 weeks, then we've got a small chance of something being concerning. If we have a demise at 8 weeks, then I would recommend that you leave the collection a little bit later, because you've got a higher chance that you're going to have a complicated result due to the breakdown of the placenta of the demised twin. If it's more than 8 weeks, I would suggest you contact the provider of your NIPT test and let them guide you as to when is the most appropriate time for you to collect that sample. And it may be as late as 15 to 16 weeks, or they may suggest that they do 2 tests. And usually the lab will do the second one pro bono. They won't charge you again. Any questions on twins and NIPT? Cool. Okay. Okay, so I'm going to move on to genetic carrier screening for case 5. So this is a couple who have 3 healthy children together, and they were referred in at 8 weeks gestation for genetic counselling because clearly their GP was on the ball and read the change in the RANZCOG statement, so sent them off for genetic carrier screening. This is a surprise pregnancy, and for them to add this baby into their family unit, they wanted as much testing as they could get. So after counselling, they opted to do the 3-gene panel, which is cystic fibrosis, spinal muscular atrophy, and Fragile X. As a surprise on the result, they were both carriers for cystic fibrosis, which is, I suppose, not surprising if you think about the fact that they were both Caucasian, but it is surprising that they managed to dodge the bullet and they had 3 healthy children beforehand. So now we know that this fetus has a 25% chance that it could be affected. And so this changes things for this couple. So therefore, they will go ahead and do diagnostic testing. Now, genetic carrier screening is different than aneuploidy. So these couples, these parents both carry this gene, they carry this variation. So this fetus will carry it, the placenta will carry it, every tissue will carry it. This is something where CVS is appropriate. We don't need to look at this fetus on scan. This is different to aneuploidy that happens at the point of conception. Aneuploidy happens and can happen late, whereas this happens all pre-conception. Yeah, this is passed on. So a CVS is a perfect thing for this woman to do. So she does a CVS, and lo and behold, it's not affected. And so she's 4th time lucky. But it just goes to show you that family history is not good enough. Can I move on to case 6?
Just before you do that, Karen, there's a question about preconception carrier status pathology. If it is now a recommended test by RANZCOG, can we be liable if we have not requested it and there's a poor outcome?
Oh, now I don't know if the College of GPs have changed their recommendation, but certainly RANZCOG has. It says that it should be offered. It doesn't necessarily mean that discussion needs to be complex or that you needed to go ahead and do testing. My difficulty is that the number of testing panels that you can do is expanding so rapidly, and they all don't do the same thing, that it becomes very complex. And it does take considerable time to take a family history in case there's something in the history that's going to make you think of something that's covered on one panel and not another, or to get them to understand the complexities of the test. So I know a lot of the obstetricians, for example, shall we say in a better term, outsourcing this, and they're referring them for genetic counselling by a genetic counsellor. And that way they are fulfilling their requirement without being caught up in doing an hour or 2 hours work with the couple. So there are certainly plenty of organisations, and that includes the public sector, that will, public sector I say in inverted commas because you have to be triaged to get through to them, because clearly we're in the era of genetics and they are overwhelmed with the number of requests that they're getting. But there are certainly plenty of private genetic counsellors who will undertake this work for you, talk them through their options, and then arrange for the collection of blood or saliva, and then follow the couple through and give them their results and organise any other testing or counselling that they need. I go back to the original thing though, that no genetic counselling has a Medicare item number associated with it as yet, and so there is an out-of-pocket cost with that. But I know that's a long-winded answer, but I don't know that I can answer, would you be held liable? Certainly that's the whole purpose that Mackenzie's mission is around, trying to look at whether this is financially a viable thing. But I think you should at least raise with your patients that there are panels out there, and some of them are quite simple and will cover the 3 most common inherited disorders. Mm-hmm.
And just a question, we had a couple, and keep asking the questions because the Q&A is dropping in and out for us. So we will try and answer them as we go, but put them back up if we haven't necessarily. Just a question here that we seem to need to use amnio to confirm a genetic problem with the fetus. Why do we bother with CVSs if we're needing to confirm it is fetal with an amnio?
So I think that's where I go back to what your fetus looks like on ultrasound is important. So if the fetus looks normal and there's a chance of confined placental mosaicism, then an amnio is definitely the preferred test. If the fetus looks abnormal in terms of its structure, then that's different. Yeah. Then regardless, if you find something on CVS, then at best the fetus must have a mosaic of what that result is. So it's more about, does it all fit together or does it not? If it doesn't fit, then we need to go on and do the appropriate test. Is that a reasonable answer?
Yeah, I think Maggie and I would both agree, and certainly we do exactly what Karen has just done. Each case is really assessed individually in this setting, and we'll suggest, okay, if we have this result at this point, depending on then what we find on a tertiary or quaternary level ultrasound, we'll make that decision to say this would be a sensible test, or actually we might counsel to suggest that waiting for an amniocentesis might be in fact a better way to go in this particular clinical scenario. So there's no particular blanket rule other than, as we mentioned, those generic. Maggie, would you work in a similar fashion?
Yeah, and I think CVS has a role in that it can be performed earlier. So often you've got a woman who's had a test and is supremely anxious, and you then going to tell her she has to wait 3 or 4 weeks for a result. In a situation like a high risk for T18 with a very normal looking baby, that's a very reasonable thing to do, to say to wait. But in a situation where you can see a baby with multiple anomalies that looks all the world like it has a brain problem, a heart problem, a growth problem, a limb problem, to make her then wait 3 or 4 weeks to confirm
is unreasonable. Yeah.
Absolutely. And we, very much try and individualise that to the woman and the couple at the time when we will discuss and consult with them.
Okay, so last case, K6. So case 6 is a couple, first pregnancy. They're referred in for NIPT testing at 10 weeks and 3 days, and plus or minus carrier screening. When you go into the family history, there is a brother that has autism spectrum disorder. So we talk about the recurrence risk of that, which is about 1 in 150 or so. We then go on to discuss the options that she has. And this patient decided to opt for the expanded carrier screening panel, which at the time covered 301 genes. So she came back positive as a carrier for Smith-Lemmy-Opitz, and her partner was unaffected. So then when we go back and look at her family history, if she's a carrier for Smith-Lemmy-Opitz, it means she had to get it from a parent. So that has then reflexly triggered for her parents to be tested. Now, it probably can't be her dad if you think about it, because Smith-Lemmy-Opitz is usually worse in men than it is in women, but we test them and we find that her mum is a carrier. It also then reflexly triggers that we test her brother with the autism spectrum disorder, and it is found that he also has Smith-Lemmy-Opitz. So this is an example of how we have used our genetic carrier screening to go back and help diagnose the disorder that the brother had, which was not detected when he was investigated as a young child. The mother of our patient then wrote us a lovely letter thanking us for actually coming up with the diagnosis for her son, because since birth she had blamed herself and thought that she had done something wrong. which is lovely, but it's more that it just reflects that there can be implications for family members when you actually find something on your genetic carrier screen panels that you do. So just go into it with your eyes open. And I think that's enough cases.
Karen, it's Sandra here. We've gone beyond our time a bit.
I'm so sorry.
That's quite all right. We've got quite a collection of questions, and I'm just wondering, do you think we could possibly get answers for those after the event, and we can email the questions and answers out to the attendees with their certificates?
Certainly.
Fantastic. And Talat, I believe you just wanted a quick look at
1 minute. I just wanted to share 2 resources. One is around MotherSafe, and I find this really helpful if there's been any any insult that the woman has had during the pregnancy. They offer a wide range of phone counseling, and I've now had a couple of times that I've had the patient with me and rung MotherSafe, put them on speakerphone, and then documented. And it obviously includes a lot of exposures that the women or we might be worried about. So that's it's based out of Royal Hospital for Women in Randwick. And if we're super worried, we can also get them to have a face-to-face consult with the medical doctor, who's a pediatrician there, Dr. Deborah Kennedy. The other thing I wanted to highlight is around Get Healthy in Pregnancy. This is connected onto our website, or you can go into it directly, and it's a free coaching. I'm sure everyone is aware that it's 10 sessions of free health coaching, which looks at both lifestyle in terms of diet, in terms of exercise, in terms of alcohol avoidance. And it's specifically, the research shows that yes, when we give them a pamphlet, a number of women sign up, but when we actually directly refer into the service, it's a higher take. So please, I would encourage our team to get the actual referrals, which are on the website, and for the benefit of our patients, get them to access this free service. Thank you, Sandra.